Thank you very much, Simon. That was very clear and timely. Next up, we've got Miss Jo Cresswell from Middlesbrough, current Secretary of the Section of Oncology, and she's going to talk about bladder cancer.
Morning. Great to be here. So, very exciting year for bladder cancer. Great BAUS week for bladder cancer. Long been a Cinderella of the oncology world. I think times are a-changing, and I'd like to tell you about why. So, let's start with our new NICE guidance. This is the first bladder cancer specific guidance, and although it perhaps hasn't told us a couple of things we'd like to have heard, like let's do more robotic cystectomies, for example, or what to do when you've got no BCG, it has, I think, given us a lot of strong recommendations that are pretty common sense. Strong patient voice in these guidance, trying to reduce variation across the country. I've picked out a few highlights. Those of you who are here at the session on Tuesday will already know this, but basically for low-risk disease, a lighter touch. We need to do less in these patients. Interestingly, NICE have strongly advocated the use of PDD, NBI, and biomarkers at diagnosis, or at TURBT. They admit there's mixed evidence in this area, but there it is. We need to classify our patients at the MDT with risk classification, a bit like we do for prostate cancer. That way we set them on the right pathway, and we can also identify them for appropriate trials. The bladder cancer specialist is an evolving person, and this is particularly important for your high-risk patients. You need someone who can take your patient, can talk to them about the pros and cons, the subtleties of whether they risk progression with their intravesical BCG, or whether they take their risks with their radical cystectomy. And I think you need somebody who does both of those things to be able to put across the nuances of that conversation. Similarly, for muscle-invasive disease, we have had a strong message from NICE that we need to be seeing these patients with an oncologist and a surgeon. They need to know what the relative pros and cons are between the two treatments. Adjuvant chemotherapy for node-positive and high-risk disease, there is evidence accumulating. Sternberg published that back in December. And clearer guidance for follow-up, that's always going to be welcome for all these patients. I'm going to flag up some more guidance that's due out this month. The suspected cancer referral guidance. It's not yet published, but it is going to affect your hematuria clinics. So I would watch this space. Now then, BCG has been sent to trials since 2012, and I certainly know through the section that we get more inquiries about this than probably anything else. Now, there's updates. There's a good outline on the BAUS website. Hugh Mostafid wrote that. There's also stuff in the European Journal, and AUA have brought out guidance. Follow the guidance. Choose one of the options from it. TICE is in short supply. We are promised Connaught will be back. I haven't seen it yet. There are papers that say that it matters which strain you give. Beggars can't be choosers. Take whatever you can get, in my opinion. Now, the guidance pretty much looks at the evidence, and the strongest evidence remains in giving reduced dose. Try to get them to 12 doses or a year. Prioritise your high risk, your T1, G3s, your carcinoma in situ, and have a conversation with those that are fit enough, should they be having a radical cystectomy instead. There's other options for your G2 high grades. Look at that. And device-assisted therapy, there's a lot of evidence coming through for that. I'll touch on that in a moment. But do not be dismayed, because I think this is a great opportunity. There's nothing like having a shortage of your standard of care to be a fertile ground for innovation. So let's use it that way. Let's look at novel agents. Let's support the trials. We've been very lucky this week at BAUS. We've had 2 UK surgical trials in non-muscle invasive bladder cancer reported right here at this meeting on Tuesday. John Kelly led both BOXIT and HIM. I think as a urology community, we can all pat ourselves on the back for delivering on this trial, as well as we have with the SUSPEND study. This is great news for UK urology. A one-liner for BOXIT. If you give your COX-2 inhibitor, your high-risk patients with BCG may do a little better, but it might be at the cost of a cardiovascular event. For HIM, BCG refractory disease. Thermotherapy probably has the edge for the papillary disease. CIS, the jury is still out. We've got 4 trials in this area at the moment. I've pinched pout because it's urothelial. Sorry about that, Simon. Caliber, low-risk disease. Chemoresection versus your standard of care. Photo, new diagnosis tumours, white light versus blue light. HIVEC2, intermediate risk, hot mitomycin versus cold mitomycin. These are all on the NCRI website. You can all get involved, and we should make these trials work for us. I've picked out a few papers. There's loads out there. You'll all have your favourites. Robotic cystectomy, great topic, lots of discussion yesterday. There's a couple of trials. I've picked out this one because it's the one that's most talked about, Memorial Sloan Kettering. So open cystectomy versus robotic. Less blood loss with robotic, that keeps being a recurring theme. Takes longer if you do it robotically. Oncological outcomes, it seems they're equivalent. Now here's the crux of the matter, as Indy Gill told us yesterday. These studies looked at open diversion. If you make it an intracorporeal diversion, it is likely to be a different story. Watch this space. Coming back to device-assisted, Tom Arends works with Fred Vitches in the Netherlands. He presented at the EAU a study for the primary treatment of intermediate risk and high risk disease, thermotherapy versus BCG. Thermotherapy did well. I think that will be published in full later this year. Basic science. Sorry, Simon, but this one's worthy of mention because bladder cancer in Nature has got to be a reason to read it. So it's genomics. Seth Lerner at the EAU told us about this, also discussed at ASCO. Why does it matter? Lots of mutations in bladder cancer, apparently. Lots of opportunity for targeted therapies. This is one to watch for the next few years. Back to home shores. I hope Kevin Gallagher is in the audience somewhere. But Kevin works in Edinburgh. He's one of our trainees in the UK. He won the best paper at BAUS this year. Mark Soloway and I thought he did really well with his presentation of PDD versus white light TURBT, showing that 3-year outcomes were better for PDD. So well done, Kevin. Finally, what's next? The BAUS cystectomy data set. It'll be published next year. 2 years data, 2014 and 2015. If we want to argue the case with the commissioners about any type of cystectomy, we have to put up or shut up. So put your data in if you're doing radical cystectomy. It's going to be coming out next year. We need to get more sophisticated with our outcomes, PROMs, quality of life, quality assurance. UCL and Bristol have both shown really, really good results with their intracorporeal diversions. Let's see what we can do further. Someone answer their phone. Randomised controlled trials of extended lymph node dissection may or may not tell us something we don't already know. Immunotherapy, checkpoint inhibitors, it's all the rage for melanoma, it's coming for bladder cancer. And innovative techniques, en-bloc resection for TURBT is still much talked about, and intracorporeal robotic diversions and reconstructions. There is a lot more to come, I think. Thank you very much for your attention.